Good evening and congratulations to the IACTA and Dr. Murlidhar for organizing this annual workshop on virtual mode, and thanks for making me a part of it. Now let me share my slides. Okay, so I'm going to talk on assessment of one of the very important functions of the left ventricle, that is the systolic function. As you know, if the systolic function is good, the cardiac output is good. If the cardiac output is good, the blood pressure will be good, and the tissue perfusion, and so will the oxygenation be good. Overall, the functional capacity and the life of a patient is very good if the systolic function is good. So I have nothing to declare. So as I mentioned, it is one of the most common indications for performing the echocardiogram because of the importance that I have just mentioned. It has consistently been shown to be a good predictor of morbidity and mortality, and therefore ASC recommends evaluation of every echocardiogram. Now this is how the ventricle looks like. It is ellipsoid in shape with a broad base and narrow apex. It has three types of fibers: the longitudinal fibers, the circumferential fibers, and the radial fibers. The circumferential fibers, they contract in a clockwise and anti-clockwise fashion and are responsible for the ringing motion or ringing effect of the myocardium. The longitudinal fibers, they lead to longitudinal shortening, and the radial fibers lead to radial shortening of the ventricle. So by assessing the changes in the shape and size of the ventricle, you can actually assess the left ventricular systolic function. So you can do this by either measuring linear measurements or in M mode. These are single dimension, useful only in normally shaped ventricles, or you can improve it by measuring the area. This is better because of more better than the single dimension measurements. But however, apex is frequently foreshortened in these patients. There could be endocardial dropout, and it is blind to shape distortions. Further improvement is by way of volumetric measurements, and there is no geometrical assumption in this, and it is unaffected by foreshortening, and it is more accurate and reproducible. So let's look at the various methods of assessing the LV systolic function. It could be quantitative methods in terms of linear measurements or fractional shortening, fractional area change measurements, or volumetric measurements. Several methods, but modified Simpson's 5-plane method is the one which is recommended. Then you have the semi-quantitative measurements such as dP by dt, tissue Doppler imaging, myocardial performance index, and MAPSE or mitral annular systolic excursion. Then you have finally qualitative methods such as eyeballing and regional wall motion abnormalities. Then there are some newer developments such as 3D LV strain and strain rate or speckle tracking. And finally, a recent development is the assessment of pressure strain loop as against the pressure volume loop, which you might have heard of. Pressure strain loop has been added to the list of these various methods. In the interest of time, I will not be covering all of them. I will give importance to only some of them which are more relevant and more important methods of assessment of the LV function. So let us start by qualitative assessment. Let's look at this eyeballing of this ventricle, transgastric short axis view. You see a good LV here, good contractility of the LV as against this ventricle, which is a very poorly contracting ventricle. So almost akinetic. So if you have a very good systolic function and very poor systolic function, the two extremes of function, the eyeballing is very useful and very easy. However, if you have something intermediate, such as this, then there could be a variation in the assessment of LV function. Some may label this as 35%, others may label it as 40%, and yet others 45%. And therefore, you should avoid visual estimation of the LV ejection fraction, and ASC recommends that even experienced echocardiographers should regularly cross-check against the calibrated measurements. Let's now move on to the quantitative evaluation, and the first in the list is the linear measurement. It's very simple. It has lowest inter-observer variability, and even a novice can perform it. It gives an accurate estimate of systolic function only in healthy subjects because only two walls of the ventricle will be sectioned at any given time. And if those two walls are normal, then your LV assessment, functional assessment will be normal. If the other walls which are abnormal, they cannot be detected by this particular method. So in presence of regional wall motion abnormalities, it is not accurate. So this is how it is performed. You have the transgastric short axis view, drop the M mode cursor on the inferior wall and the anterior wall and measure the end diastolic diameter and end systolic diameter. Substitute the values in this equation and you get the fractional shortening. In a patient who has got inferior wall motion abnormalities such as hypokinesia, here you can detect the LV dysfunction by measuring the LV end diastolic volume and pressure. But however, if the lateral wall and the inferior wall, lateral wall and the septum is abnormal, then you cannot detect the, you cannot accurately detect the systolic dysfunction. Let's move on to the area measurements. It has got an improved accuracy over the linear dimensions, and you can measure it by way of fractional area change. So you measure the LV and diastolic area and systolic area and substitute the values in this equation and you are able to get the fractional area change. The normal values for men are between 56 to 62 and women 59 to 65%. You get a transgastric short axis view in end diastolic frame or a largest or the biggest picture or dimension of the left ventricle and the smallest of the end systolic frame, and you measure the area, include the papillary muscles in your measurement, and you get the left ventricular fractional area change. It is easy to use and it has got good correlation with the ejection fraction, and the endocardial dropout can be overcome by automated border detection. It can also be overcome with the help of contrast enhanced transesophageal echo, which is with the help of ultrasound enhancing agents such as agitated saline or the inert gases which are available now in the market, which are also FDA approved, and they improve the endocardial border detection as is shown here. You see that the contrast nicely delineates the endocardial border and the accuracy of the measurements of fractional area change can be improved. Now let's move to the left ventricular volume measurements such as ejection fraction. For this you need to measure the volume, and the method is to, as I mentioned, is the modified Simpson's formula is applied. It is a percent of LV diastolic volume ejected during the systole, and it is calculated by measuring the end diastolic volume and systolic volume, substitute the values in this equation, and you get the ejection fraction. It also gives you one more important information, that is, if the LV systolic volume is more than 70 ml, it indicates that there is an increased risk of postoperative morbidity and mortality. So that's also another important parameter if you are measuring the volumes. Now, as I mentioned, modified Simpson's rule is applied, for which you need to measure two axes. One is the LV minor axis just above the papillary muscles, and another is the LV major axis from the annulus of the mitral valve to the apex. And these are utilized in this formula, and the LV volume is measured by dividing the LV into 20 equal cylinders, the volume of which each cylinder is measured by the help of this formula, and the total volume is calculated. And this is the only method recommended in the recent AAC guidelines regarding the volumetric measurements. So you have two orthogonal planes sections. One is in the pore chamber. You measure the LV volume in end diastole and in end systole, and another in two chamber, again in end diastole and end systole, and you average the values and you get the ejection fraction. The problem with this method is the foreshortening, which means that you are sectioning the ventricle at the virtual apex, not the true apex. And this happens because if you want to avoid this, you should retroflex the probe in order to section the true apex. And this can be verified by looking at the motion of the apex. If the LV apex is moving towards the mitral annulus during contraction, it indicates that the LV is foreshortened. Whereas if it is not immobile, then it indicates that the LV is not foreshortened. So this simple method can be used. So the retroflex the probe and watch the LV apical motion in order to rule out the foreshortening and improve the accuracy of your measurements. Let's examine the stroke volume measurements, for which you need to have the deep transgastric view. So the direction of the flow is across the LVOT and the aortic valve and the ascending aorta. So the Doppler beam is in perfect alignment with the direction of the blood flow, you obtain the spectral Doppler, envelop the tracing, and you get the velocity time integral multiplied by the cross-sectional area, which is obtained by measuring the diameter of the LV outflow tract, multiplied by the heart rate, and you get the cardiac output. Now, all these calculations are performed by the inbuilt software of the machine. All you need to do is to measure the velocity time integral and the LVOT diameter. So if in case you are not able to get the deep transgastric view sometimes, which is a possibility, so you can obtain this transgastric long axis view where you can see the LVOT again is a fairly good alignment with the direction of the Doppler alignment with the direction of the blood flow. So this can also be used for measuring the stroke volume of the cardiac. Let's look at some of the semi-quantitative methods. The first one is the dP by dt. So rate of increase in the pressure over time. So faster the rate of increase in the pressure indicates a good LV function. So it has a good correlation with the systolic function. Greater the contractility, the greater the rise in ventricular pressure. And for which you need to have the mitral regurgitant spectral Doppler profile in order to be able to measure the dP by dt. So you measure the pressure at two time points. One is at the flow rate of 1 meters and another is at the flow rate of 3 meters. So calculate in order to calculate the pressure at these 2 points, you take help of the modified Bernoulli's equation, which is 4 into velocity square. So at 1 meter, the pressure is about 4 millimeters of mercury, and at 3 meters, the pressure is about 36. So the difference between the two is 32 millimeters of mercury divided by the time which you measure between the 2 points, which gives you the rate of rise in pressure, which in this case is very less. The normal value is more than 1200, and the ventricular dysfunction is present if it is less than 800 millimeters of mercury. Now, for measuring the there's another method where you can drop these lines in order to improve the accuracy of the measurement of this time at 1 meter and 3 meters. You can also increase the sweep speed in order to improve the accuracy of measurement of this time interval, which is relatively short, and you can increase the sweep speed. For measuring the dP by dt, you must have the presence of mitral regurgitation, and if it is not present, you cannot measure it. Absence of MR does not mean good LV function, and also remember that presence of MR does not mean bad LV function. All it means is that you will be overestimating the LV systolic function. So now let's move on to the tissue Doppler, which is a very sensitive and very easy method with relatively less inter-observer variation, and also relatively load-independent method of evaluating the LV systolic function. In this case, Doppler is used to measure the tissue velocity. So instead of measuring the blood velocity, we are measuring the tissue velocity, and for which low-pass filters are used to screen out the higher velocities generated by the blood flow. And this is how the picture looks like. This is a post-chamber view. You press the tissue Doppler button and you get this type of pictures. That's the medial mitral annulus. This is the lateral mitral annulus. Drop the pulse wave Doppler, and you also narrow down the sector. Here I have narrowed the sector on the medial annulus in order to improve the frame rate and the resolution. And then you apply the pulse wave Doppler and you get a waveform of this kind, or the spectral Doppler in this manner. One systolic wave, which indicates the contractility or the motion of the annulus, mitral annulus towards the apex, and two diastolic waves, E prime and A prime. S wave is called as SA. A stands for the annulus. So let us focus our attention on the SA velocities because we are evaluating the systolic function. A normal velocity is more than 7.5 centimeters. It indicates normal global LV function. If it is less than 5.5 centimeters, it indicates LV failure. And if it is less than 3 centimeters, it's a significant risk factor for cardiac death within 2 years. So it's a very important and very simple parameter in my view if you want to assess the, and a quick parameter to assess the LV systolic function. Let's move on to the MAPSE, which is mitral annular plane systolic excursion. Just as you have TAPSE on the right side, you have the MAPSE on the left side. What you do is you measure the lateral mitral annular plane movement towards the apex during the systole. And M mode beam is positioned at the lateral mitral annulus, and the normal values are more than 10. They indicate the preserved ejection fraction. If it is less than 8, It indicates the decreased LV ejection function. You need to drop the cursor. This is a four-chamber view. You drop the end-mode cursor onto the lateral annulus and measure the distance here of the motion of the annulus towards the apex. That gives you the MAPSE. Now, Bode and colleagues have studied this in a little bit detail and have given us the normative values in Indian population, and they have given a cutoff value of 9 millimeter for lateral and 7 millimeter for septal MAPSE to define the LV dysfunction. And they also validated these numbers against a group of about 100 odd patients and found that the sensitivity and specificity is fairly good with this measurement. It is especially useful in poor sonographic windows and also is an objective method that provides simplicity and ease of measurement with little inter-observer variation. So it's again a quick method for assessment of the LV function. Global longitudinal strain is another method, which is again a very sensitive and early marker of LV systolic dysfunction. In fact, it detects the preclinical LV failure before the ejection fraction decreases. The global longitudinal strain can fall. Strain means change in the length of an object within a certain direction related to its baseline. So that this is the formula. So LT is the length at a time t, and L0 is the initial length at time 0. So the normal value is -16 because LT means the longitudinal fibers, they constrict and the length decreases after the contraction. Therefore, you get a negative value. And anything more than -16 is such as -18 or -20 is considered as normal. And less than -16, such as -14, would be considered as LV dysfunction. Now, it is impaired. An impaired intraoperative GLS is associated with prolonged hospital stay and epinephrine requirement, and it has also been shown that it is an independent predictor of early postoperative mortality, even in those patients with preserved ejection fraction. As I mentioned, that it is an early indicator of systolic dysfunction. Let's move on to the speckle tracking of the strain, which should become a routine part of the LV echocardiographic examination, and it is suggested that complete picture of LV function only can be obtained by using multiple modalities that we have discussed so far, of which speckle tracking should be one. So that's the importance of global longitudinal strain or speckle tracking. Unfortunately, it is vendor-dependent software, and it varies from from machine to machine. And the AAC is trying to resolve this issue by it has formed a task force which is trying to streamline this problem of this vendor dependency and trying to bring it on a common platform so that there is uniformity in the assessment of the speckle tracking of global strain. This picture shows the 3D assessment of the volumetric assessment and the myocardial segments and the speckle tracking, which is showing the regional wall motion abnormalities or regional changes in the strain of the left ventricle. So I will not go into the details of this. Finally, I wish to tell you about the LV pressure strain loop. You might have heard of pressure volume loop, but pressure strain loop, which is pressure plotted against the strain. And based on this, you calculate some parameters. One of them is LV global work index. It is important because in the presence of decreased global longitudinal strain, if the global work index is normal, it indicates that the LV is still compensating and the outcome will be better as compared to those where the global longitudinal strain has also decreased and the global work index has also decreased. This is currently being evaluated and being assessed in larger studies, so we'll get more information in times to come. Finally, I wish to tell you some of the recommendations, recent recommendations of the Journal of the AAC, which are all measurements should be performed in more than one cycle, preferably in 3 cycles and in 5 cycles if the atrial fibrillation is present. Same range of normal values for LV and RV dimensions apply for both transthoracic as well as transinsufficient echo. And to allow comparisons between individuals, it is suggested that you must index the various values to the body surface area. Although this is one of the recommendations, in practice, I do not see many people following this particular guideline, and most of us do not index the various values that we get to the body surface area. Also, they mentioned that calculating LV volumes from linear LV measurements are no longer recommended for clinical use. What is recommended is the Simpson's formula to measure the volumes. LV systolic function should be routinely assessed using 2D or 3D. So it is not 2D and 3D assessment. So any one of the two is okay. So 2D, if you do not have that 3D facility, 2D is still okay. We do not know how long this is going to stay. Normal values also have been provided. Some of the normal values as LV and diastolic volume in men as 74 ml, LV and systolic volume 31, and ejection fraction of 53 to 73%. Finally, these are some of the ejection fraction values given at mildly, moderate, or severely depressed LV dysfunction that have been given normative values. Again, these are not applicable, may not be applicable to Indian population, and we should try to get normative values for our Indian population. So I would like to conclude by saying that LV function is the most common assessment that you perform during any echocardiogram. There are a number of parameters are available, but ejection fraction is most commonly used. And I think tissue Doppler is an important parameter and gives you a very good indication of the global LV function. MAPSE and speckle tracking are also being investigated, and they appear to be very simple measurements of LV systolic function. And comprehensive assessment is necessary before you can commit about the LV systolic function. So thank you very much for your kind attention, and I'll be happy to take some questions. Thank you.